everyone, and welcome to Faces of Digital Health, originally a podcast about digital health and how healthcare systems adopt technology, with me, Tjasa Zajc. I've spent the last few weeks researching what are the reasons, causes, and numbers behind medication-related errors, deaths, and patient-related harm. It's a huge topic, it's a challenging topic. A lot of statistics refer to studies that have been made 10 or 20 years ago. So the estimates are really hard to make because in the last 10 or 20 years, a lot has been made on the side of increasing patient adherence with technologies, with medication apps. And at the same time, technologies are being developed to make prescribing of medications easier for doctors and prescribers. On June 29th, I'm going to air a documentary called Overdose, How Can We Prevent Medication Errors? And I invite you all to join us. The link is in the show notes. But as part of that documentary, which was recorded with the help of 10 speakers from across the world, I decided to expand the awareness campaign around this challenge and will post the discussions that were recorded for the documentary as separate discussions for the YouTube channel or for the podcast. So do tune in, subscribe to the podcast if you're interested in the topic and want to see it from the patient, nurse, doctor, and clinical pharmacist perspective. We're going to start this special series with David Kliff, who has been living with diabetes for several decades. He is a well-known author of the newsletter called Diabetic Investor. He's been following technology, the medication advancements, and knows very well what the psychology behind having or dealing with a chronic disease is. And as you will hear in this discussion, there's a lot of factors that contribute to numbers in adherence, and consequently patient-related harm with medications are higher than we might expect them to be. Enjoy the discussion. As mentioned, subscribe to the channel or to the podcast, and we're going to dive right in the discussion with David. This was first meant to be only a discussion for the documentary, but because it contains so much rich data, I decided to publish the whole discussion. It just starts in the middle of our conversation. So enjoy and let's dive in. You were talking about insulin dosing in the hospitals.
Yeah, so one of the biggest issues in any hospital setting is when you have a patient who's using insulin, again, depending on what they're in there for, how do you make sure you're properly dosing them, okay? So a lot of the, hospitals, some hospitals have started to adopting CGM technology and incorporating that into their IT systems. This company, Biotech, what they do is they come up with optimal insulin dosing in a hospital setting. Now, the goals are always a little bit different, okay? Because the way hospitals are compensated, they don't want to readmit, so they want to get them out of the hospital as quickly as possible, and they don't want them coming back right away either. And for any diabetic patient in a hospital setting, it adds a complication that not everybody's used to. There's a thought process that, hey, I'm in a hospital, I'm with a bunch of doctors, they should know what they're doing. The problem is some do and some don't. And, so if you're not experienced with, dealing with a diabetic patient, it's a little bit different. Now, everybody's trying these different systems, okay? They're, like I said, we have better technology today, we have insulin dosing algorithms, we have all these things. But again, the hospital setting is probably, again, depending on what the patient's in there for, is probably the most difficult setting to be in. And so I think, everybody wants to obviously you want to do no harm. You don't want to have a severe hypoglycemic event, nor do you want a severe hyperglycemic event. You want to do your best to keep them in a good range. But it is a very demanding area because of what I would say the non-traditional factors. It's not like, somebody just managing their diabetes on a regular basis. You're in a hospital. You're getting poked and prodded every couple hours. You're not sleeping probably like you normally do. You're not eating like you normally do. You're not exercising. You're under stress. I mean, all of these are complicating factors that even if somebody follows, let's say, the protocol to the letter, doesn't mean there's not going to be an issue. So I think the goal has become, let's mitigate the chance for error. So where in the old days, you had lots of errors, maybe now you're cutting that number down to, instead of, and again, I don't know the numbers, I'm speaking in hypotheticals. Excuse me, let's say you had 10 errors a day in the past. If you can get that down to maybe 1 or 2 errors a day now, that's a pretty good improvement. Mm-hmm. And I think that's the drive with almost every piece of technology for anybody who's using insulin today, whether it's continuous delivery through an insulin pump, whether it's a connected system with a pen, whatever. You want to make sure that you're getting it as optimal dosing as possible without doing any harm to the patient.
Mm-hmm. You've been in the diabetes space for over 20 years. Is it possible to describe a little bit, how the whole medication landscape has changed from the patient's perspective? So the amount and the number of different medications is higher, the treatments are improving or getting more sophisticated. Is the management of medications for patients getting any easier? Can you compare how it was 20 years ago to how it is today?
The answer is yes and no. There's no question the drugs we have today are much better. Insulin analogs are better than the old human insulins. GLP-1 therapy has become widely accepted as even the drugs we have, the SGLT2s, the drugs are better. The technology's better. We have CGM now instead of BGM. And plus we have phones. Everybody's got a smartphone. So everything talks to everything now. So yet, even with all these great advancements we've had, technology, drugs, you name it, we still have a problem because a lot of patients don't follow what they're supposed to do. So even though we have a lot of great stuff, the same statistic keeps coming up over and over again in that 70% of the patients, and it doesn't matter whether they're insulin users or not, are not under what they define as good control. So there's a disconnect between all of this great stuff that we have and the actual results. The one item that cannot be controlled in this chain of events is the patient. And there's so many factors that have to be taken into account that aren't, quote unquote, directly diabetes related. So let's say you have a patient with either no insurance or a high deductible insurance. Well, there's a lot of patients in that situation. So what do? They skip doses. Well, that doesn't work. They're skipping doses because they can't afford it. Even in places where everything is given to them. Sometimes they don't do it because they forget. They don't like the side effects. What most patients want is not to have diabetes in the first place. Okay? Since they can't have that, The next thing they want is diabetes management made stupid. Okay, something they just do every day without even having to think about it. So the problem has come that, I think a lot of the platforms that I've seen, especially in the digital space, they have the opposite effect. They're there to help, but it's a constant reminder to the patient. Oh my God, I've got a chronic condition. Oh my God, I got to do this. Oh my God, oh my God, oh my God. I got my kids to pick up from soccer. I got to make dinner, whatever. They really don't want to be reminded every day what they have to do and how to do it. I think some of the drugs, I'm a big believer in GLP-1 therapy because to me it's the dumbest therapy on earth. You inject yourself once a week. You don't have to measure your blood sugars. More than likely the patient's going to lose weight. That's always a bonus. So that's a therapy that to me is extraordinarily stupid. We all do something once a week, whether it be go to the grocery store, the laundry, whatever. And plus the new GLP-1s, whether it's Trulicity from Lilly or Ozempic from Novo, not only are they once weekly, but they use a very small, short needle, so you can't really say that they're not painful to inject, and so that's a real easy therapy to get somebody on, because it's stupid. The same, NovoNordisk right now is working on a long-acting insulin that could last for 24 hours. The idea is very interesting because the theory is the less injections you need, the more you're going to do it. So this is kind of where less is more. I'm not sure, given the business dynamics of diabetes, that drug will see the light of day. We have long-acting insulins now. You only take them once a day. They're pretty good. Even if they could work through the hurdles of getting this thing, let's say, to last for 3 days, hypothetically, I'm not sure that would clear the business hurdle. Because, here in the States, you're talking about, you got to get coverage. You don't get coverage, you're not on formula, you don't have a business. So, I continue to believe that we are making good progress, but until we get to a point where what I call the average patient, I'm not talking about somebody like me. I'm a overeducated patient with access. I'm a boy with my toys. I wear a CGM, I wear a pump, I exercise, I do what I'm supposed to do. But in my patient population, there's probably only 10%. And then you go all the way on the other end of the spectrum, you've probably got 20% of the patients. They're disengaged with their diabetes and never will be. But in the middle, you have 70% of the patients. They know they have diabetes. They know they need to do something about it. They want information, but they also want it as dumb as possible. And medication adherence or compliance, or whatever the proper term is these days, is the biggest obstacle between better outcomes. So I think that part of that has to do with patient education. A doctor, what happens? Patient goes in, they go see their doctor. Typically, what do? It's almost, I call it treatment by failure, because they follow the playbook. Okay, they put them on a bunch of pills. If they don't work, okay, then we put you on something else. Again, this is kind of how healthcare is structured. But you don't know what damage is being done to the patient while they're treating the failure. And so, it's, and there's also what I call the guilt factor. A lot of physicians use guilt. Doesn't really work. I had a mother, she tried to use guilt on me, it never worked. Okay, same thing with patients and physicians. Oh, if you don't take your drugs, I'm going to put you on the needle. When they probably should be on insulin to start with. You know, this is, you know, you start to, what people I think fail to realize is that they're not dealing with a computer, they're dealing with a human. And a human who has all kinds of concerns. You know, and that's why so many physicians, even with insulin therapy, really dumb it down. They say, okay, I want you to take 30 units of Lantus every night and 5 units of NovoNordisk with every meal. And they don't care what you eat or what you're doing. Because they just want to dumb it down. Because they figure, and I do understand the mentality, something is better than nothing. And, you know, so typically what happens is, you know, it's kind of a weirdo cycle because, you know, you got to get the patient back into that office a few months later to say, hey, is it working? You know, so, you know, like I said, even with all these great advances, and we've had, I mean, and this is, you know, it is not an understatement. We have some of the best drugs. We have some of the best devices. We have open access to information. Anywhere in the world you are, literally you're carrying a computer with you. You know, so you can Google, you know, anything. And I think that's great. But again, you know, getting somebody, as I've said a million times, I can give you the how to do this. That's the easy part. I can't give you the want to do it. You know, I want to do it because I know what could happen to me. But I'm not your normal patient. You know, I'm training for my 9th triathlon. You know, somebody says, well, you know, that's crazy. You're a type 1 diabetic. I'm like, I said, I can do anything I want as long as I know what I'm doing. And, you know, so, and, you know, in some areas, you know, there's like this, almost like this stigma. You know, if you're a diabetic, you're not a leper. I mean, you know, if somebody comes up and touches to me, I'm not going to transfer my diabetes to them. You know, but I know people who are like, they're almost what I call closet diabetics. They won't tell anybody. You know, they're ashamed of it. You know, maybe it's a cultural thing. I have no idea. But, you know, it's not. You have to be at least a semi-engaged patient to see decent results. So I don't care how good the medications are, and they're great. Don't get me wrong. I mean, Lily's working on trizipatide, which to me I think is going to be an incredibly outstanding drug. You know, you've got all kinds of delivery systems now. You know, you've got pens, you've got pumps, you've got inhaled, you've got, you know, people are working on patches. I mean, and, you know, it's not like the options are not available. They're all there. So, you know, and you've got, you know, some of these drugs, I think one reason I'm also a huge believer in GLP-1 therapy, not only is it stupid, but the patient sees some benefits. They're losing weight. And diabetes is not a disease state where I walk around and walk into a room and somebody says, oh my God, Dave, your A1C looks good. You know, you don't get that constant positive. You know, if you're losing weight, you walk in a room, people say, hey, you look great, you lost weight. That's constant positive reinforcement. That means that you're going to keep taking the drug. And so, and diabetes is unfortunately a disease state where by the time you really feel bad, it's too late. You know, diabetes is a slow killer. You know, it's, you know, as I tell people all the time, somebody doesn't get cancer from smoking one cigarette. They get cancer from smoking a series of cigarettes over a series of years. Diabetes is very similar to that. Mismanagement of diabetes won't get you right away. That would be rare or odd. But over a series of years, why do you believe a disproportionate number of complications happen to people who are, let's say, 65 or older? Okay, it's not because they started mismanaging their diabetes when they hit 60. It's because of a series of years. So these are the kind of issues that everybody faces today. And again, I love the new stuff. I think it's great because we are getting and really, what I love most is the access to information is there. You no longer have to go to a doctor's office. You can do virtual consults. You have apps that will help you. You can talk to your CDE via text message. So that kind of stuff I think is great because the more the patient knows, the better they're going to be. And they want to feel like they're an active participant. They're not being told, hey, you have to do this. They just want to know why. Too often they're not given them. They just said, you got diabetes, let's do it. And I think that's changing, which is a good thing.
Mm-hmm. To which extent do you think that adherence to medication can potentially decline once you have a chronic condition for a very long time and you get some sort of a kind of confidence that you know the disease, that you know what you need to do, and that kind of brings a little bit of overconfidence regarding how serious the situation might be. So if you have a condition for 10 or 15 years, then it's really something that you got used to it in one way or another. And I think at that stage, it's potentially easier to say that something might not be serious, if you know what I mean. If something occurs that you get.
Well, I think the biggest change we're going to see, and we're starting to see this now. It's not big yet, but it's starting to come up. Is that we're looking for non-diabetic factors to motivate these people. So my prime example is this. A lot of auto insurance companies put a device in your car. It monitors how you drive. Based on their driving habits, you could have lower insurance rates. So what the driver is trading, the driver saying, I'm going to give up some of my privacy. You're going to know how I'm driving. But in exchange for that, you're going to give me a lower premium. Diabetes management really should be no different. There's a lot of ways to measure diabetes. HbA1c is only one of them. Continuous monitoring is obviously another one. There are still patients who use conventional meters. That's another one, assuming you're doing it often enough. But a way to engage the patient is incentivize them in some way. Make diabetes real to them, something they can touch, something they can feel, something that they can see. There are programs now. United Healthcare has a program that's beginning to use incentives. I think I'm very intrigued by it because I'm a huge believer in that. And because it's something the patient can see. So, an employer, for example, they can eliminate your copays or your deductibles or whatever. The better you manage yourself, the more things you get. It's kind of almost like a frequent flyer program on an airline. The more you fly, the more perks you get. Okay? So, chronic disease, whether it's diabetes, or any other chronic disease, really is no different. If the patient has a vested interest in the outcome, and, then, I don't want to be crude about it, but in a way you're bribing them. But it's no different than if you go out and buy life insurance, they charge higher rates for smokers and non-smokers. So you have an incentive to quit if you smoke. You're getting life insurance. You have incentives. So I do believe that's one of the things that is kind of, there's a lot of weight loss programs right now that are based on incentives. I love these kind of things because it makes the disease real to them. It makes them take ownership of it because they're getting, you can be completely out of control and you don't really feel bad. It's not like if you have a broken arm, okay, you put a cast on it, you wear the cast, you get it x-rayed, and you can see improvement, whatever. Diabetes isn't like that. You don't. I know patients who have A1Cs of 10, and they feel fine. They don't feel anything. It's not like a headache or a backache. Unfortunately, by the time those pains do arrive, it's too late. That's when you get the blindness, the kidney failure, the amputations. But so you're really asking, in a way, you're almost asking the patient to take a leap of faith, meaning that if you do all of these things, you're going to avoid all of this other stuff. Now, we can't guarantee that, but there's a pretty strong likelihood. Most human beings, well, it'll happen to the other guy, not me. This is human nature. And I know a lot of people hate when I say this, but it is very true. Diabetes is not just a chronic disease state, it's a lifestyle. And you have to adapt your life to your diabetes and vice versa. And I think that's where, this has been a problem. I mean, I've been writing Diabetic Investor for over 20 years. And if you go into any physician's office, I don't care whether they're primary care or an endocrinologist, you go into any physician's office and you say, what's the biggest hurdle standing between your patient and better outcomes? 9 out of 10 would say medication adherence. If we could just get them to follow the program, they'd be fine. And that's been around for over 20 years.
You mentioned before how complicated managing a patient with diabetes can get in a hospital. Do you know of an example, or do you have an experience where something would go wrong with prescribing, if there was an error or a wrong dose or anything, and how that played out?
I don't personally have any experience with that, but you read about it and you hear about it all the time. Mm-hmm. I talk to people who are endocrinologists or diabetes researchers who are based in a hospital system, and everybody has a horror story. A nurse that is new on the floor, didn't know how to dose properly, and missing. I know this sounds crazy, but even like a doctor's handwriting, okay? I know everybody makes fun of that. One reason I love tablets, okay? Because there's no chance to where a 4 looks like an 8 or whatever. And so I think what's happening is, this is for all the technology that's designed to help, you still have humans using the technology. And, I think that, and you have to remember what it's like to be in a hospital. Okay. Something's always, especially nowadays, with COVID and all that stuff, there's something always going on. So what happens? A nurse, gets called to an emergency, doesn't deliver the insulin they're supposed to. So that what happens? A patient goes into, might go into DK. Who knows? It happens. It's a hospital. It's not as controlled an environment as everybody believes it is, because there's always something going on there. And so I think everybody's doing their very best to. There's no way to eliminate these errors entirely. I always believe the goal is let's lower that error rate as low as humanly possible. Because, as I tell people all the time, I wear medical devices. Sometimes they fail, okay? It's a piece of machinery. It's inevitable. I mean, nothing is perfect. You know, we carry around our cell phones. You know, sometimes we have outages. You know, we don't like it, but it happens. These are things we have to live with. But I believe there are, I think, to me, the best possible news is that in order to solve a problem, you got to recognize you got one. And I think what hospitals are beginning to learn is we're not perfect. We make mistakes. Let's eliminate those mistakes. And, you know, I mean, there's all sorts of factors. You know, better training is one of them. You know, making sure that not just the nurses and the doctors are better trained, but all the technicians, the people who are actually, you know, filling the scripts, all of that, you know, it's a whole supply chain, basically. So hopefully, you know, and you know, that's why I believe that, you know, you can't eliminate errors entirely, but you can mitigate the number of errors. And there's a common, you know, like I was mentioning earlier, this GlyTech insulin dosing system for a hospital. Even if you talk to people at GlyTech, they'll tell you straight up, we can only do so much, but we're doing our part. So, you know, and that's becoming more and more common. I don't see technology as being the answer by itself, but it's definitely part of the solution.
Mm-hmm. Maybe just one more thing we didn't mention before. Is it possible to say or to describe, you know, what's the kind of the usual number of medications a patient with diabetes will have? Let's say he has a disease for over 10 years. It's kind of an ungrateful question because I know that some, you know, if you are a compliant patient, that I'm sure you can be better off. But like, if you have multiple comorbidities, how does
That's not a bad question at all. And that's another factor is that, you know, I've worked with so many companies and I try to explain to them and said, you know, you got to realize. Now, I'm very lucky. You know, me personally, other than diabetes, I got nothing else, okay? Although my children might beg to differ. But most patients with diabetes have multiple things that they're managing, okay? So they're not just taking meds for diabetes. They're probably taking a statin. They're probably taking something for hypertension. You know, they may be taking a few other things. So, you know, I mean, you know, you look at some of these people's, you know, the little pill things, you know, they have, you know, and, you know, they're filled with medications. And so you can't view diabetes in a void, okay? Which, going back to your earlier thing, is another factor a hospital has to consider. You know, which drugs work with, you know, can I do this? Will it change that? You know, and I don't remember the latest statistics, but the last numbers I saw, they said the average diabetic patient is taking, I believe it was 4 other medications besides what they're taking for diabetes. And also think about this. Not just the number of medications that you're taking. Think about how often you have to take it. A lot of doctors, when they're doing what I call diabetes by the numbers, you know, I want you to take metformin 3 times a day. Okay? Take it, you know, when you get up in the morning, take it at lunch, and take it at dinner. Okay? Well, okay, it sounds simple, right? But, you know, how many patients have I talked to that, you know, okay, the first dose is pretty easy because they're at home, okay? But then you got to remember, okay, do I have my pills with me? You know, I know this sounds stupid, but that's how it is in the real world. Oh, you know, somebody's out to lunch, I forgot my pill. You know, it happens. So it's not only the numbers of meds, but how often that you take them. and it's not like a patient can like double up, meaning that, oh my God, I forgot my afternoon dose. I'm going to take 2 tonight. That's not how this works. You know, they're designed to be taken, and it's, you know, so, you know, you add in all of these factors, and that's why I'm saying that there's the final disconnect that I really see, that, and I don't know how this will ever be solved. To get the patient and the clinical world on the same page for what is considered good outcomes is very difficult. You know, if you brought in a room of 20 diabetics, and I don't care how they're managing, I don't care if they're on orals alone, orals plus insulin, insulin alone, I don't care what they're doing, and you ask them to define good control, you're going to get 20 different answers, okay? You go in a room of 20 clinicians, they're going to basically tell you, get me an HbA1c of 7 or below, okay? I know it's, you know, but that's really, you know, and patients don't think like that. Patients think like, how do I feel? Do I feel good or do I feel bad? You know, and, you know, so to get those people into the same, what do they call it, singing from the same hymn book, you know, that I'm not sure that's doable.
Yeah.
So, you know, that's a tough problem. I'm not sure that's doable.
Yeah, I totally agree. You know, I have IBD, and luckily I don't have too many issues, but I have a friend who's got a more severe form, and I know that, you know, over time you kind of get used to bleedings and everything, so you don't really take them seriously until it really starts to hurt. I think, like, once she called me and she said, I think my you know, my colon kind of fell out a little bit. Do you think I should go to the doctors? And I was like, So yeah.
No, but it's, you know, but it's so true. It's like, I mean, I'll give you an extraordinarily real life example. The only reason I know I have diabetes is because my wife made me go to the doctor. I mean, I was your typical guy. You know, I never went to see a doctor. You know, I was feeling fine. You know, listen, now you're talking, this is way, way back in the day, but I mean, I had all the symptoms. I just didn't know it. And my diagnosis was like a slam dunk. But, you know, that is a real world example. You know, I'm like, okay, the only reason I went to see a doctor was to get her off my back. You know, so, you know, it's the way it works.
Yeah. It's interesting, you know. That's kind of what I was trying to allude to before. I might not have been too successful, but I was recently asked, like, what do I think is missing in the inpatient care at the moment? And, like, from my experience as a chronic patient, I've been a chronic patient for 17 years by now. And that it's kind of like what I said before. My situation is quite well managed. I don't have too many issues. In 20 years, a lot has changed in terms of what matters to doctors, what kind of therapies are available. But, you know, I'm still living in the world 17 years ago when I actually cared about the trends and the disease and what I need to know and what's going on. And now I know what was known 17 years ago, but I have the confidence that I know enough for me, you know. And it's my response to that question was, I think patients sometimes need a little bit of perhaps a nudge or re-education about their condition to overcome that confidence that they know enough.
Oh yeah, sometimes, yeah. Oh no, I agree.
Yeah.
Yeah.
Well, this was great. I'm out of questions. But yeah, I will keep you posted.
My pleasure. Need anything, feel free to.
Yeah.